Hello, everybody. I am Dr. Mervet Abu Gabal, Professor of Internal Medicine and Rheumatology in Shams University. Welcome to the presentation of these few musculoskeletal ultrasound findings made during my work at Rheumatology Unit that belongs to Rheumatology Department in Shams University Hospital. My topic today is please don't miss this. As I said, my topic today is please don't miss these. Now, what are these? These are a group of musculoskeletal ultrasound findings related to bone irregularities other than osteophytes or erosion, also related to tendon pathology. My first case was 55-year male with 6-year history of rheumatoid arthritis. He had bilateral wrist synovitis as detected by musculoskeletal ultrasound examination. This is the image of his right wrist with synovial hypertrophy and posterior Doppler signal, mostly grade 2 at right radiocarpal and mid-carpal joints. On examination of volar side of the third finger on the right side at this patient, overlying the proximal interphalangeal joint, there was palmar plate avulsion. As you know, palmar plate is essential or function to prevent hyperextension at the joints. Once there is palmar plate avulsion or tear of palmar plate or lesion of palmar plate at its proximal attachment, there will be hyperextension of proximal interphalangeal joint here in this patient, which is the first step in development of swan neck deformity in rheumatoid arthritis patient. So please don't miss this lesion in patient with rheumatoid arthritis, as this is an early abnormality that occur in swan neck deformity and could be treated conservatively by finger fixation and spleen to prevent permanent swan neck deformity. So please don't miss this. My second case was a male, 19-year-old, with 3 years history of rheumatoid arthritis. The patient was on conventional and biologic DMARDs that result in remission of rheumatoid arthritis disease, except at both wrist joints, where there was active synovitis at radiocarpal and mid-carpal joints. This is the image of his right radiocarpal and mid-carpal joints with posterior Doppler signal and synovial hypertrophy. And this is the image of his left radiocarpal and mid-carpal joint with grade 3 active synovitis of these joints. On examination of his right wrist volar side, there was abnormality at the scaphoid bone. The bone contour was abnormal, hazy, not apparent, which indicate presence of pathology at right scaphoid bone. In this patient, taking large doses steroid to control active persistent synovitis despite conventional and biologic DMARD, the first possibility was occurrence of either osteoporotic fracture, but no history of trauma, even minor trauma at rest of this patient. Or another possibility is occurrence of steroid-induced avascular bone necrosis of scaphoid bone, to be confirmed by MRI to exclude this pathology or any other pathology like, for example, bone tumor. So please don't miss this bone irregularity in patient, especially when kept on large dose steroid for a long time to detect or early diagnose presence of avascular bone necrosis, presence of fracture, presence of bone tumor to be confirmed by MRI. So please don't miss this. Our third case was female, 50-year-old, with suspected diagnosis of osteoarthritis with or without calcium pyrophosphate deposition disease. She had active synovitis at radiocarpal, mid-carpal, some metacarbophalangeal joints but mostly grade 1, together with osteophytes at most of proximal and distal interphalangeal joints. But on examination of polar side of her left wrist joint, there was synovial hypertrophy and positive Doppler signal surrounding flexor carpi radialis tendon, which indicate presence of tenosynovitis of flexor carpi radialis tendon. At the same time, there was a step or defect at left scaphoid bone. On examination of flexor carpi radialis tendon longitudinally till its insertion into second and third metacarpal bone, the tendon itself was near its insertion was swollen, hypoechoic, which indicate presence of tendinopathy or encisopathy of the tendon. Even there may be tendon tear, partial tear. At the same time, there was bizarre shaped or abnormal irregularity at metacarpal bone, the second and third metacarpal bone, which indicate either presence of fracture or presence of bone abnormality in general. Again, there is, to confirm the picture, also there is abnormality, especially in second metacarpal bone phase. On revising the history with the patient, she gave history of previous fracture at distal forearm and wrist, which may account for this distorted anatomy and abnormal shape of or irregularity of metacarpal bone, especially the second one, which may be fractured during the previous fracture together with malunion. So, to confirm also presence of distorted anatomy and pathology at her left flexor carpi radialis tendon insertion, we examine the right flexor carpi radialis tendon insertion into second and third metacarpal bone, and this is the normal appearance. So please don't miss this bone irregularity like that was present at insertion of flexor carpi radialis tendon, which may point to presence of previous fracture and malunion in this patient. Please don't miss this. Our next case was a 39-year female with bilateral knee arthritis, few months duration. This patient was previously diagnosed as systemic lupus erythematosus and was kept on large dose steroid. On examination of musculoskeletal examination of her knee, especially the right knee joint, there was active synovitis. There was synovial hypertrophy. There was a positive Doppler signal together with synovial effusion, which indicate active synovitis of right knee joint, together with presence of medial suprapatellar plica. On examination, musculoskeletal examination of her upper medial tibia, there was severe tenderness on sonopalpation, together with appearance of periosteal elevation, which may point to the presence of periosteal avulsion in this female with systemic lupus erythematosus, or even presence of periostitis with or without underlying osteomyelitis in this systemic lupus patient taking large dose steroid. So please don't miss this finding, especially in presence of severe tenderness on sonopalpation. Don't miss presence of periosteal elevation that may point to periosteal avulsion, underlying osteomyelitis, or periostitis. Our next case was a female, 29-year, complaining of a swollen left fifth distal phalanx. On examination of her left fifth little finger at distal part, there was no synovitis, tenosynovitis, or enthesitis or encisopathy around distal interphalangeal joint. But after end of the middle phalanx, there was a sudden distortion or abnormality, irregularity of distal phalanx with abnormal bone contour. It was displaced downward with increased thickness of nail bed together with appearance of hypoechoic lesion at nail bed immediately overlying the downward displaced irregular distal phalanx. On examination by Doppler ultrasound, there was highly vascular lesion at nail bed just overlying the displaced irregular distal phalanx. This lesion was confirmed by MRI and biopsy to be a giant cell tumor of bone. So please don't miss this bone irregularity that may point to the presence of tumor arising from the bone or eroding into bone. Don't miss this. Our next case was 40-year-old female without definite rheumatologic diagnosis. She was referred for steroid injection of her second extensor compartment at breast due to presence of tenosynovitis. There was active synovitis at radiocarpal and midcarpal joints bilaterally and at some metacarbophalangeal joints in this patient. This is the image of third metacarbophalangeal joint, which show grade 3 active synovitis with synovial hypertrophy, positive Doppler signal, and narrow joint space indicate chronicity. On examination of extensor compartments at her right breast, there was tenosynovitis of second extensor compartment containing extensor carpi radialis longus and brevis with synovial thickening and positive Doppler signal. The patient was referred for steroid injection for this compartment, second compartment, with tenosynovitis. But on ultrasound examination of the adjacent third compartment that contain extensor pollicis longus tendon, the tendon was absent at breast. On following the extensor pollicis longus tendon distally till its insertion into base of distal phalanx of the thumb, the tendon is still absent with possible avulsion of the base of distal phalanx of the thumb, which indicate the presence of torn, retracted extensor pollicis longus tendon, which was retracted proximal to the wrist. So it was absent at the wrist and absent all through till its insertion into distal phalanx of the thumb. So we revised the history with the patient and revised our clinical examination. Our clinical examination revealed lost extension of interphalangeal joint of the thumb, which confirm torn extensor pollicis longus tendon. Also, the patient gave history of previous recurrent infection at nail bed of the thumb and around or at distal phalanx, for which she received multiple courses antibiotic. So please don't miss the presence of torn absent tendon, especially in presence of nearby infection. Sure, in this patient, it's not suitable to inject the second compartment due to with tenosynovitis with steroid in presence of nearby infection. So please don't miss this. Our next case was female, 25 years, with differential diagnosis of rheumatoid arthritis and secondary osteoarthritis versus psoriatic arthritis. There was active synovitis at radiocarpal, midcarpal, and submetacarbophalangeal joints with just effusion at some distal interphalangeal joints. On examination, ultrasound examination of her right extensor carpi ulnaris tendon, there was a fragmentation, heterogeneous or heterogeneity of extensor carpi ulnaris tendon, which may indicate either partial tear or tendinopathy of the tendon, together with mild tenosynovitis, synovial thickening, and positive Doppler signal in tendon sheath of right extensor carpi ulnaris tendon. On ultrasound examination of left extensor carpi ulnaris tendon, the tendon was normal, but the tendon sheath show mild tenosynovitis. On following the extensor carpi ulnaris tendon on the left side till its insertion at the fifth metacarpal base, there was a circumferential abnormality surrounding the the tendon. There was significant synovial hypertrophy, positive Doppler signal, together with anechoic fluid collection around the tendon, which indicate either presence of localized severe tenosynovitis or presence of giant cell tumor of the tendon. She's to be confirmed by MRI and by biopsy. On examination, longitudinal examination of this tendon by ultrasound, the tendon near its insertion at the base of fifth metacarpal showed hypoechogenicity and delamination, which indicate tendon, partial tendon tear, also surrounded above and below by synovial hypertrophy, positive Doppler signal, and anechoic fluid, which, as I said, may indicate presence of localized tenosynovitis or giant cell tumor surrounding and eroding into the tendon. So please don't miss to follow the tendon both proximal till myotogenous junction and distal till its insertion, even if there is apparent mild tendon pathology in the tendon or in its sheath at the rest. Follow the tendon proximal and distal. There may be another more serious or more severe pathology. Please don't miss this. Our last case was female, 49-year-old, with 3 months complaint of dorsal right wrist swelling and pain. On musculoskeletal examination of her both hands, no synovitis in radiocarpal, midcarpal, metacarpophalangeal, or distal interphalangeal joints. But on examination, musculoskeletal examination of extensor compartments at the wrist on right side, there was mild tenosynovitis of extensor compartment 4 or of tendon sheath of extensor digitorum tendon. More distally, distal to the rest, the tenosynovitis was more severe with septation, anechoic fluid collection, positive Doppler signal, and more synovial hypertrophy around tendons of extensor digitorum muscle. Also, this tenosynovitis of extensor digitorum tendon extended till the mid hand or the mid part of the hand, as you see, with fluid collection, synovial hypertrophy, and positive Doppler signal. Please don't miss to count the tendon slips, especially in presence of pathology, either at tendon sheath or the tendon itself. For example, here 1, 2, 3, 4 slips of extensor digitorum tendon together with a small slip for extensor indicis. These are the tendons present at compartment 4. But at the same time, please don't forget to follow up the tendon proximally till its myotogenous junction. On following the tendon by ultrasound till myotogenous junction, the tendon was separated from surrounding muscle with fluid collection around with positive Doppler signal, which may indicate bleeding. So there is tendon tear at myotogenous junction. So please don't forget again to follow the tendon, even if there is apparent pathology at the rest, till its myotogenous junction proximally and till its insertion distally. Don't forget to count the slips of extensor digitorum tendon to make sure that there is no tendon tear. Please don't forget this. As you see, musculoskeletal ultrasound examination helped us to early, detect presence of bone irregularities that may point to the presence of a tumor, previous fracture, or avascular bone necrosis. So don't forget to check for this. Also, musculoskeletal ultrasound examination helped us to detect pre-deformity lesion like palmar plate avulsion, which is the first step in development of swan neck deformity, especially in rheumatoid arthritis patient. At this stage with palmar plate avulsion, the patient could be treated conservatively to prevent occurrence of permanent swan neck deformity. Also, musculoskeletal ultrasound examination helped us to detect tendon pathology, whether in proximal part all through the tendon or at its insertion. So thanks to musculoskeletal ultrasound. Thank you for your time. See you soon with another group of musculoskeletal ultrasound findings. Actually, I have a lot for you. Thank you.